Your doctor is concerned that you have injured the anterior cruciate ligament in your knee. The purpose of this video is to help you understand the nature of your injury. What is the anterior cruciate ligament, or ACL? What functions does it serve? How is it injured? What is the healing process? And what are the potential problems? How is it determined if you have torn an ACL? And most importantly, what are your options? Your knee is a complex structure made up of bones, ligaments, tendons, muscles, and other tissues. Each of these tissues has a specific function. Working together, they allow a normal range of motion. There are 3 bones in the knee joint: the femur or thigh bone, the tibia or lower weight-bearing bone, and the fibula. Ligaments stabilize and control fine movements of these bones. These ligaments include the MCL, or medial collateral ligament, the LCL, or lateral collateral ligament, the PCL, or posterior cruciate ligament, and the ACL, or anterior cruciate ligament. Several tendons surround the joint, attaching muscle to bone, adding stability, and enabling you to move the joint. At the top of the tibia, 2 crescent-shaped pieces of cartilage called menisci serve as shock absorbers and protect the knee. The ACL can be compared to a short segment of rope with interwoven fibers in the middle of the knee. It attaches to the back of the femur and the front of the tibia. Like a rope, the ACL provides only a pulling force in the knee, helping to control the fine movements between the thigh and lower leg. The ACL assists in preventing hyperextension of the knee and allows certain twisting motions. When excess forces are applied, the ACL can stretch an additional 10% of its length before it fails or ruptures. This is most often an all or none phenomena, although sometimes ACL injuries are seen where the ligament partially tears. When the knee shifts and the ACL tears, the overlapping fibers can unravel just like a rope and put stress on other structures. Overall, with a torn ACL, there is about a 50% chance of an associated tear of either the medial or lateral meniscus. The articular cartilage on the ends of the bone in the joint can also be damaged in roughly 10 to 20% of ACL injury cases. In more severe cases, other ligaments may also be injured. Your doctor's evaluation of your knee injury will include taking a history. You will be asked how your knee was injured, whether there was a pop or shifting sensation, swelling, pain, or previous injury. A physical examination will involve gentle touching and manipulation of your knee in order to determine the area and nature of the injuries and the amount of looseness from the torn ligament. In some cases, the excess bloody fluid will be drawn out of the knee with a syringe. This process, called aspiration, may be required to help find out more about your injury and reduce discomfort. Additional tests may also be ordered. X-rays can show any additional bony injury. The knee arthrometer can be used to measure the extent of increased looseness of the knee. An MRI scan or magnetic resonance imaging may be ordered to help confirm the extent of the ACL injury and to look for other associated injuries such as meniscus tears. An MRI produces a computer image of your body's soft tissue, revealing more detail than an X-ray photograph can provide. By itself, the anterior cruciate ligament has only a limited healing potential. If the ACL is absent in the knee, there are significant short and long-term risks. There is a consensus that with an ACL injury in an active patient, there is a high risk of recurrent instability episodes where the knee might shift suddenly and then swell and become painful for a period of days. This usually happens with activities requiring sudden changes in direction, jumping, stopping, or activities on uneven ground. Roughly 50% of active patients with new ACL tears will experience these problems within the first year. This carries the added risk of further injury to other structures in the knee, including the meniscus. The risk appears to increase as time goes on. It is also known that there is an increase of long-term risk for degenerative joint disease or arthritis of the knee following an ACL rupture. Treatment for the torn anterior cruciate ligament can be roughly divided into two major groups: conservative or non-operative, and surgery with reconstruction of the ACL. To determine what is appropriate for you requires many considerations. 1. The magnitude of your ACL knee injury. 2. Individual factors such as your age, overall health, and the physical demands you put on your knee during work and recreational activities. 3. Your willingness and ability to accept some limitations and modify your activities. And finally, 4. How your knee has responded to conservative treatments such as rehabilitation. Your doctor will help you work through these factors and make an informed decision. It is not urgent for you to make an immediate decision concerning your treatment option. ACL surgery is often delayed for 3 weeks or more after injury, allowing the knee to quiet down. This seems to help limit knee stiffness after surgery. Furthermore, ACL surgery can still be successful months or even years after injury, especially if careful conservative treatment has been used to limit further damage. Conservative or non-surgical treatment initially involves measures to help reduce the pain and swelling in the knee. 4 letters, RICE, represent your immediate care: rest, ice, compression, and elevation. This is followed by efforts to regain motion, strength, and function of the knee. Education, rehabilitation, and possibly a knee brace worn for moderate risk activities will help prevent re-injury. A very important factor in a successful conservative program is your willingness to accept some limitations and to modify activities. It is generally thought that the recurrent giving way episodes and associated symptoms of pain or swelling can be controlled in roughly 1/3 to 2/3 of patients with these careful conservative measures. Even if you and your doctor agree to try conservative treatment, you may experience persistent or recurrent knee problems requiring at least limited surgical intervention. Your doctor may use a technique called arthroscopy. This involves making 2 or 3 small incisions around the knee while you are under anesthesia. Sterile fluid is inserted into your knee to expand the joint, providing better access. The arthroscope is like a miniature camera lens that allows your doctor to see clearly inside your knee joint. The scope relays pictures to a monitor for the doctor to see a magnified view of the joint. Small instruments can be inserted through the incisions, allowing your doctor to work inside your knee, much like a dentist works in your mouth. Surgical treatment to restore the ligament function generally involves reconstruction of the anterior cruciate. This procedure replaces the torn ligament with a new band of strong tissue. This should not be confused with a direct repair or a sewing together of the ligament, which has not worked well in the past. Generally, in reconstruction, the new tissue is routed into the knee through drill holes in the tibia and femur, so that the new ligament goes through the knee at the same locations where the previously ruptured ACL was attached. This new tissue can be fixed inside the bony tunnels in a variety of ways, sometimes using metallic screws, staples, or sutures, which may be seen on post-surgical X-rays. Usually these devices are left in the knee and do not require removal. The tissue used for the graft varies. Currently, the most common graft tissue is a central third of the patellar tendon from the same knee. An option is the use of hamstring tendons from the same knee. Another option is the use of an allograft or tissue from a deceased donor. After the natural death of a donor, the allograft tissue is tested for AIDS and hepatitis and frozen until use. The allograft is thought to have nearly as much healing potential as a graft from your own body, but it does carry the considerations of added cost and the very low likelihood of disease transmission. A fourth option is the use of a man-made graft. This is normally used only in special circumstances and can be discussed with your doctor. The surgical incisions on your knee will vary according to the preference of your doctor. your particular type of injury, and the type of graft chosen. As with most surgeries, there are several risks, including infection, a blood clot in your calf, numbness next to the skin incisions, and the very low risk of major nerve or artery injury. Other risks with this kind of reconstruction are the possibility of knee stiffness requiring difficult physical therapy, and the risk that the graft could fail or stretch, leaving your knee unstable and loose. The overall success rates may approach 90% for achieving a stable knee with good motion and strength, which will allow most activities. Most patients will find that the knee is not as normal as it was before injury. The reconstructed knee may fatigue a little quicker. Some patients feel a click with certain motions, and some experience persistent numbness next to the incision. The actual surgical experience will vary with your specific situation. The evening before your surgery, do not eat or drink anything after midnight. The morning of surgery, you will check in at the admissions desk to fill out some paperwork. Personnel will direct you to a pre-surgery waiting area where you will change into a gown. You and your anesthesiologist may elect a spinal anesthesia, numbing you from the waist down, or a general anesthesia, making you sleep. Your doctor will be assisted by other personnel. This type of surgical procedure is generally performed between 45 and 90 minutes. When your surgery is over, you will be taken to a recovery room. Your leg will be elevated and may be supported in a brace. A surgical drain may have been placed in your knee to remove any excess bloody fluid. The drain is usually removed before you go home. Hospital personnel will monitor your progress as you regain consciousness. Depending on your circumstances and special planning by your doctor, you may be able to go home at this stage. Problems such as excess pain or nausea may dictate a one-night stay in the hospital, but this is not common. You may also be visited by a physical therapist during your hospital stay to begin gentle range of motion activities and practice the RICE techniques: rest, ice, compression, and elevation. When it's time to leave the hospital, you will need friends or family to drive you home. Your knee may be supported in a knee immobilizer to protect it during the healing process. Crutches will be used to assist you in walking. It is important not to develop an abnormal walking pattern, so follow your doctor's instructions. The trend in recent years has been to put more weight on the knee within a few days following surgery. Many patients will be completely off crutches in 7 to 10 days. Once at home, following your doctor's instructions may include using the RICE techniques to control pain or swelling. Prescription medication may also be used to make you more comfortable. Prescriptions can be obtained at the hospital pharmacy or local drugstore. Adequate rest remains an important factor in your recovery. Plan on spending a few days at home in bed or on the couch. It is easier and safer to sponge bathe for the first few days. This eliminates the need to stand for long periods and protects the wound from getting wet, which may contribute to infection. Your recovery is based upon your treatment and the rehabilitation program you follow. The rehabilitation process begins directly after surgery. Your doctor and physical therapist will work together to develop a program that best suits your individual needs. In general, the prescribed exercises and activities will gradually progress in order to decrease pain and swelling, and then to regain motion. During this process, you should regain strength and finally regain function and balance. There is always a slow, controlled return to activities within about 6 to 12 months following surgery. Again, depending on the status of your knee after surgery, low-risk activities will be added first, and high-risk activities added last. Your knee will be monitored to ensure safe progress. It is very important to keep in mind that the graft heals very slowly. Your knee may look and feel great just a short time after surgery. However, it takes up to a year or more for the graft to heal completely. Your physician may prescribe the use of an ACL functional brace for activities. Commonly, the functional brace is recommended for high-risk activities 1 to 2 years after surgery. Rehabilitation requires your personal commitment, along with that of your therapist, to return your body to its previous physical condition. Continuing your fitness program will only benefit your health. Remember, your knees are essential to support most of life's physical activities. The anterior cruciate ligament injury is complex and often more serious than you might imagine. Several decisions are to be made regarding your treatment, and hopefully, with the help of this video, you will be better able to discuss the specifics with your doctor. Although this is a serious injury, with the appropriate recognition and understanding, treatment can be provided to help prevent recurrent injuries and restore your knee function. You play a major role in the treatment of this problem by taking responsibility for your knee and accepting restrictions and limitations to prevent re-injury. If surgery is involved, you are making a long-term commitment that may span several months. Your dedication and compliance will lead to the best possible results.